Thank you, Dr. Ganji. And that was just an amazing talk by Dr. Kanako Holmes. I'm just so lucky to have her in our organization. So I'd like to now introduce our next speaker. Dr. Gerson Galdamez is a gerontologist at the Davis School of Gerontology from the University of Southern California. He has a special focus on his research in security in late life among Latino immigrant groups. He is an emerging leader in the field of elder abuse, as well as economic disparities among seniors and equity and aging policy. He's already shaped public policy through his work with the Archstone Foundation and SCAN. He recently completed a very prestigious four-year fellowship in health policy research through the Robert Wood Johnson Foundation. And it's just a pleasure to have him here. We're very happy to have him share his very, very timely talk on the Latinx community, elder mistreatment, and the current COVID era. So welcome, Dr. Galdamez.
Thank you very much. It is a privilege to be here. And I'll say that those of us in the research community extend our gratitude to the practitioners listening today. I know it's frustrating during the pandemic for us to feel like we're not in that work and having a tangible effect and change on helping people. So you inviting me to talk today about elder abuse, COVID-19, and the Latinx perspective is something I'm very appreciative of, because it makes me feel like I'm contributing in some way to such a tragic period of time in our lives. So thank you very much. And we can go ahead and get started. So my name is Gerson Galdamez. I'll be talking about elder abuse, COVID-19, the Latinx perspective, and how they work together. So I'd like to start off with some acknowledgements. These are my mentors that you see on the screen, Dr. Kathleen Wilbur and Zach Kasumis at the Leonard Davis School of Gerontology, as well as Dr. Laura Mosqueda, who's a well-known expert, geriatrician and expert in elder abuse. So I'd like to start today with Today I Remember. I'm remembering someone called Mr. B. His name wasn't actually Mr. B, but he was someone who, when I was young, I volunteered a lot as a musician in different senior homes. And I developed a lot of really close relationships with the older adults there just over time. And Mr. B was someone who I had a really particularly strong connection to, because he himself was a musician. And, I was in junior high and high school. So over time, we got into some conversations just about his life. And it became pretty clear to me that he had been verbally abused by his family. There were a couple of other markers of abuse that I didn't know back then were markers of abuse, but I definitely felt like something was weird. And I had this feeling as a young man of like feeling helpless, not being able to help Mr. B with some of the abuse that he was tolerating from his family that visited him. And so that was a very formative experience for me. So when I was deciding what to do with my career, those experiences really informed my decision to pursue not just gerontology, but specifically elder abuse. So today I'm remembering that. So a little bit about who I am. I am the son of immigrant parents. I am Guatemalan, Salvadoran, and Mexican. I was raised by my grandmother and mother. So my grandmother just turned 86 this past Valentine's Day. And my mother and my grandmother were both nurses. So, and my mom's currently, on front lines dealing with the pandemic as a nurse. So, all that to say that I do have sort of a personal stake in this topic, and I also represent the wide heterogeneity of the Latinx population. So, really happy to be the one to relay this information to you all today. So a little bit of the roadmap that we're going to go on. So I'll give just a very brief overview of elder abuse and delve into some demographics, so largely background information. I'll speak a little bit about Latinx individuals and their risk for elder abuse, Latinx individuals and their risk for COVID-19. And then I'll bring it together and talk about the intersection of those three topics. And then I'll conclude with some recommendations from me and the Secure Old Age Lab at USC. So we can start with just a definition of elder abuse, which I'll say is harm or risk of harm to what we call a vulnerable elder by a caregiver or a person in a position of trust. We can also define it as a failure by a caregiver to provide basic needs to an older adult or prevent harm from coming to an older adult. And in terms of general prevalence, we say that elder abuse affects 1 in 10 older adults in the United States and can include physical abuse, psychological, or we also call emotional abuse, sexual abuse, financial exploitation, and neglect. And we also sort of lump this other phenomenon we call self-neglect, which we lump together, but we also kind of carefully separate, because the older adult in that case is also the victim and the perpetrator of that type of quote unquote abuse. So, and then there's a picture of an iceberg there, because we use that 1 in 10 number a lot. It's really easy to remember, but there's a lot of issues with data collection for elder abuse. Very difficult to kind of get a really good number. So we say that 1 in 10 is actually just the tip of a pretty big iceberg. So there is likely that there's a lot more abuse going on than what the numbers tell us. And additionally, the resolution of elder abuse cases can be really complex. So all those types that I rattled off earlier, including self-neglect, can intersect. So they can happen at the same time. The wishes of the older adult can conflict with their own well-being, which makes it really hard for practitioners to see the path forward. And there's an administrative burden. So a lot of these cases require legal services, medical services, social services to come together, do a lot of strategizing and even paperwork. And a lot of these services are traditionally siloed, so they don't really communicate as smoothly as they could. So all that to say that the resolution of cases is something that is an ongoing effort in specifically the research world. So a brief overview of Latinx demographics. Latinx individuals are 17% of the US population. And we can see in that figure there that it's definitely grown and continues to grow. So it's projected to reach 107 million people in the US by 2065. In Los Angeles County alone, Hispanics and Latinx individuals comprised approximately half of the 10 million person population. And in Orange County, they comprise about a third of the 3 million population. So definitely talking about a significant chunk of our population. And so it's worth understanding sort of the nuances involved. So I have a note here just for all of you to consider that we're not talking about a monolith. We're really talking about a population with considerable diversity in culture and approaches and attitudes. And so that makes it beautiful, but also much harder for me to give sort of sweeping recommendations. So please keep that in mind. And I'll also have reminders in the presentation just for that purpose. The Latinx Elders and abuse, in terms of prevalence, it's pretty difficult to gather data on Latinx elders, in part because it's hard for researchers to gain trust in that community. So what we do have is a study of about 200 elders in the Los Angeles area. We've discovered that about 40% of them experienced some type of abuse, and about 21% experienced multiple abuse types. And you'll see the breakdown of the types there. And we also know that Latinx elders are less likely to report verbal and financial mistreatment than white elders. So we already know that elder abuse is an iceberg. When it comes to the Latinx population, we're talking about what we see as a smaller tip of what I think is a much bigger iceberg. So some of the risk factors involved with this population and elder abuse. For the first, which should come to as no surprise, is language and culture. So the culture and language barrier creates a barrier for services and practitioners to understand the family context, the personal context that would normally give practitioners that red flag of like, oh, maybe I need to dig a little deeper into this patient to see what's going on. The language barrier can also foster some mistrust of individuals who are mandated reporters, so like physicians and social workers, just because like you don't know what they're saying, they don't know what you're saying. So obviously that's just a difficult situation. So it confuses the process at all the stages. So from the reporting stage, getting someone to open up about elder abuse and then telling them what's going on, like we're reporting this, and all the way down to the resolution of the case. The language barrier is definitely something that should be actively addressed. And I think importantly for the Latinx population is this concept of familia, so which means family. Latinx individuals have a high preference to receive in-home care from their family. It's almost an expectation, I think. And specifically receiving care from the women in the family in particular is a pretty common expectation, obligation, burden, whatever word you'd like to use there. And this phenomenon can feed the frustration of the family in general, but specifically the caregiver. And we definitely see situations in which the caregiver is just so overwhelmed by that familia obligation that you start getting events of lashing out, that verbal abuse, maybe even physical. And then in addition, we have this concept of vergüenza, which translates to embarrassment. So you have vergüenza about, an older adult has vergüenza about putting themselves before the family. So opening up to a physician, telling them that, hey, my family is abusing me, you need to help me. It's just seen as sort of a shame in a way. And again, speaking generally, this is a very heterogeneous group. Definitely not a gospel what I'm saying here, but vergüenza is definitely a driving factor. And additionally, just as part of the culture, financial mistreatment and exploitation is often not recognized as, I suppose, like a legitimate form of abuse. For example, you can tell. I've definitely had experiences where I've told an older Latinx individual, like, these people, your family is taking advantage of you, and it's just kind of a response of, well, no, they're my family. Like, this is what I'm expected to give. I would give all my money to my family because that's sort of my belief system. That those are my values. So definitely a little bit different than what sort of the conventional approach to financial exploitation would be. So I spoke a little bit about this, but I think it's worth delving into a little bit deeper. So in Latinx families, the gender roles are certainly strong, particularly in older generations. So there's sort of an increased tolerance for abuse and higher economic dependence from the women of the family. And I think in conjunction with that is this concept of machismo, which is roughly translates to like a pride in masculinity and the traditional male role, seen as a provider and a protector. So you can already kind of see how the vergüenza piece and the machismo piece sort of feed into this fear, embarrassment of losing your status or respect, putting yourself before your family. So that can prevent an older adult from, specifically an older male Latino, from seeking help. And this can also feed into a cycle of self-neglect as well. And then also Latinx individuals, I think, particularly males, have this expectation of being the point person on communications with those outside of the family. So that kind of creates a barrier for like other members of the family to go to physicians and then tell them this is what's going on with my grandfather and my father. It can kind of be seen as like a breaking of that trust and of those kind of traditional values. So I'd like to transition just a little bit and just give an overview of kind of what's happening right now. I'm sure most of the people watching right now have an idea, but just reading some of these headlines, Latinos getting coronavirus at more than double the rates of whites in LA County, deaths rising at astonishing levels, horrifying levels, up 1,000% since November in LA County. So this idea of building trust around the vaccine, that's sort of the conversation right now. And trying not to throw too many graphs at you, but also just taking a look at that yellow line compared to the others. We're seeing that yellow line is much, much higher than even the other non-white populations in Los Angeles. So definitely topical to understand specifically the culture and the barriers we have to reaching them. So I'd like to talk a little bit now about the intersection of being Latinx, having these risks of abuse, and COVID-19. So the lockdowns related to COVID-19 have certainly compounded caregiver burden. So usually the small moments of reprieve and the activities that you do to relieve the stress in your life are severely limited by having to stay indoors and the danger of going indoors anywhere with other people. So you can imagine there's an additional concern for yourself if you're a caregiver for your older Latinx family member, and increased stress about the elder because there's such high risk for individuals who are higher up in age. So and related to that, the machismo piece, the cultural confidence piece, and the machismo kind of feeding into a non-compliance with the safety measures. You know, you have your Latinx father who doesn't want to wear the mask, right? It's seen as kind of like being weak, wearing the mask. So as a caregiver, you're sort of stuck in this situation where you're constantly having to battle to get those safety measures in place for your family. And I think also there's this huge socioeconomic piece that could honestly be its own section in a symposium. But just briefly, Latinx elders are in the labor force right now. They're facing consistent contact with other people. They're not staying at home. They're not retired. They can't retire. They face a higher economic burden than whites. They cannot afford to stop working. So having this low socioeconomic status, just to give like an example, having no smartphone or something with video capability, a physician can't physically screen you or see anything that's going on in the home. So, those traditional red flags that would lead to an investigation in a case just doesn't happen. Or they might have to visit the office to receive medical care, which then increases their COVID risk. Additionally, so there's limited to no in-person doctor's visits. So physicians can't screen for physical markers. You can't have those conversations with the family, understanding the interpersonal dynamics. This is like a very, very prevalent right now, and is something that I'm not really sure we have an immediate solution to. We also have increased mistrust in service systems in general. So I will share that my grandmother has told me, no les importa que estamos muriendo. They don't care that we're dying. So giving sort of that personal perspective of like, Latinx individuals just are not trusting of the system, and whatever trust they did have has been kind of stamped out. And I think there's this phenomenon of us seeing effects of anti-immigrant, anti-Latino narrative and the political climate from the past few years, specifically with the Trump administration. So it's kind of up to the medical community to start rebuilding that trust. And it's going to be difficult, I think. So I'd like to conclude with some recommendations from the Secure Old Age Lab. The first is that education about elder abuse is most likely best through a family advocate, because they can assist with that cultural and language barrier, especially if they're younger, because they're most likely bilingual. So it'll be important to make the information digestible for a young person. I can say that I was translating for doctors when I was like 7 or 8. So I had sort of a working medical knowledge from all of that, but I think it was important that the doctors sort of started at square one for me, so I could then relay that information in a way that I understood and that I thought that my grandmother or my grandfather could understand. And I think an important piece of this as well, just to keep in mind, is that family members are or can be abusers. So if you suspect something like that, I think it'll be important to bring in APS, use your best judgment. So just something to keep in mind. And I think this importance of the trust relationship is going to be critical. So my first point about this is that trust relationships are built over time. It's not going to happen in a 15-minute office visit. Learn people's names. So as someone with a difficult name to pronounce, Gerson, I can say it means a lot when anyone takes the effort to learn how to say my name. So don't be afraid to ask, and don't be afraid to kind of do that back and forth. Show them that you're trying. And I think maybe slightly related is learn Spanish. I can say that. So when I take my grandmother to the doctor, she's excited when a white doctor is trying to communicate in a way that she understands, because it shows that you care. So I think learning a little bit of Spanish, especially if you're a doctor in Los Angeles, I think it's very helpful. I think it could be very helpful. And in the case when you're finding that there could be potential abuse going on, there might need to be an investigation or an intervention. The primary concerns for a Latinx family or an individual will most likely be the fate of the children or the abuser. So this concept of like, I don't want my grandson to go to jail. That's going to be something that is a huge barrier, and sometimes is practitioners and professionals just can't get around. So it's definitely their big piece. The next consideration will probably be the preservation of autonomy and machismo. I think this relates back to the trust relationship. If you're kind of breaking down that feeling of being in charge, it can kind of lead to a mistrust and a closing off, in which the older adult doesn't want to share anything else about the family, about themselves. So it'll be important to kind of delicately peel back the layers. So very important. My next point is to make no assumptions. So earlier in this talk, I talked about how we're not talking about a monolith. So there are different cultures and attitudes about mistreatment and about the medical community. So learn about those through conversations over time. Each elder can be different. Each family member is different. The dynamics between them are different. So it's certainly a very wide range of situations you might be able to find yourself in. But there is certainly, just kind of groundwork and information for us to kind of to springboard off of. So also evaluate elder autonomy. Don't be afraid to separate the caregiver and the patient if you're concerned about the patient's family coercing them into saying that everything's okay. Evaluate, are they sharing their wealth and their resources? Is there anything suspicious about the way that they're sharing their wealth and resources? So again, they probably won't open up to you about this immediately on the first visit, right? So over time. And during those conversations, you can also evaluate elder trust and authority. So physicians and social workers, before taking any action, it could be helpful to give APS that context before they go in and have conversations. And if particularly complex, there are multidisciplinary teams in place that APS or the district attorney's office can mobilize to deal with cases of really, really complex abuse. So I'd like to give just a few points about Latinx elders and telehealth, just because right now, specifically in the pandemic, it's a very very prevalent use and avenue for us to connect with older Latinx individuals. So with this piece, I'd say that language interpretation and patience will be very critical to having a successful telehealth appointment with a Latinx elder. So I'm sure there are different Kaiser supports and policies and services in place for that language interpretation piece, and I highly, highly recommend that that the practitioners listening take advantage of those. And I think also there's this issue of accessibility to devices and internet service, which also relates back to the socioeconomic status piece. But I'll give just a brief case example. We had an older Latinx individual. We gave them an entire telehealth package with the iPad, with everything. And they only reached out for help on how to use it after they recovered from their illness. So you can already see there's just a barrier to access and use. And there's this kind of like, there's a stressful piece of like, I don't really know how to use this thing. So I just won't, right? So it's definitely something to consider. And then in the event that you're able to get an older adult on a screen, take a note of their hygiene. Is there visible, audible distress in either the elder or the caregiver? I think really important, not just for Latinx individuals, but in general. But I think it's important for us to take advantage of what we do have, which is a video chat. So yeah, that is the end of my talk. And I'll say that bringing it back to my experiences with Mr. B, he has since passed. So I think that story, I think, is maybe didn't have such a happy ending, but I think for the other relationships that I built in the senior homes that are still ongoing, I've been able to, using my experiences and the information that I shared here, I have been able to nudge different practitioners in the right direction for the friends that I've made. And so really grateful for having this knowledge and to be able to share it with everyone here. And I think now is the time for answering some questions and then concluding. So thank you very much.
Great. Thank you so much, Dr. Galdamez. That was truly amazing. And, what we're seeing on the chat is just a lot of interest in what you just spoke about. We have quite a few questions, and one of the thoughts I have is there was so much information that you gave, in particular in terms of an approach that it might be helpful to just double back and talk about some of those concepts. First, and just to echo your point, it's just we're so appreciative of you coming here and giving your perspective and all the evidence that you have, as well as the the grace that I think we all have to have that, this is not a one size fits all, but I think the very concept of us talking about it, and understanding that there are these dynamics already puts us ahead, just because, as you mentioned, that may not always have been the case. And, we really need to talk about these topics right now. So I did have a couple questions have popped up, and, one particularly, topic that I have interest in, and it looks like the audience does, is the concept of these cultural barriers. For example, the concept of vergüenza. What's an approach in which we can diffuse the situation and be able to address that barrier? Are there any pointers in regards to that? I think you mentioned communication is a key.
Yes, definitely. Yes. So that is a wonderful question, a beautiful question. And I think one that I can't answer with research, but I can answer with personal experience. So here's what's worked with my family. Handshakes. So a strong handshake in the beginning of an office visit has definitely helps my older Latinx male family members open up, just because it feels more like a meeting as opposed to I'm being dragged to the doctor by my daughter because I'm in trouble for, eating too much sugar and I'm diabetic or something like that. So handshakes. Get on their level also, physically and intellectually. So I think kind of not just standing there, take a seat, and don't kind of spew off like really big words. Like get on their level intellectually, understand like they don't have a medical degree, really take it slow with them, make it make it obvious that you want them to learn, and I think you'll start kind of they'll recognize that kind of effort for respect and reciprocate. So and it's difficult because of how heterogeneous patients can be, but I think I would say generally take it slow. So what would it take for you to spill a compromising secret about abuse you might be facing? It's not going to happen immediately, and you're going to be, really safeguarded and sheltered and closed off. So over time, I think it helps to say, like, you can tell me if anything is wrong. You can tell me if you need anything. I'm here for you. Hearing that consistently, I think, is something that has also worked.
I think how you open that, just something as simple as I think just the touch, the strong handshake to sort of say, hey, we're on your level, and that we're here for you, and that you're the most important part of this visit. That concept of, instead of, I can imagine, especially with communication barriers, being spoken at and being reprimanded, especially. We deal obviously with a lot of compliance issues, with a lot of our underserved communities. And sometimes, as you mentioned in your talk, it could be communication barriers. It could be just because something was not properly explained. But, we do see sometimes the practitioner attitude is just to sort of say, well, why aren't you taking care of yourself? You're at fault. Why aren't you smart enough? Why aren't you educated enough? And you could see how that can automatically break down the relationship. So I love what you just said about just going in there, strong handshake, engagement, and then again, taking it slow, making sure they understand. One thing that does bring up, though, is the generational issues that you brought up in terms of needing to give respect to, for example, the head of the house. The issue of machismo. If you have like a son and a daughter, and the head of the household in the room, that concept of machismo, and how do you approach it without offending, but allowing the kids to advocate? And is there a perspective you have on that particular piece?
Yeah, I mean, I'd say in many ways that is an even more difficult question, but I think in my experience, it has helped to separate them. So having the older adult in one room, the daughter, whoever else, in another, and giving them the information separately and then together, for some reason, has worked. I'm not a psychologist. I don't know why it works, but it has helped for me, just because I think when you're having teaching moments with a patient and their family advocate, it can be easy for either one of them to start interrupting and start kind of playing the blame game. You're talking about diabetes, and the daughter starts saying, like, you need to stop eating ice cream, all this other things. So kind of taking that out of the equation and building an understanding separately, and then having them kind of come together, I think has helped. And I think also, if you're in a situation where, the daughter or the son or whoever is starting to blame the older adults and kind of chastise, I think it's helped for the doctor to kind of intervene and say, like, we're not trying to blame you, we're trying to move forward and help. But I think also I'll say that, like, practitioners should know their limits. So not all of us are trained as like family therapists. So sometimes the situation is just so complicated and heated and has a lot of a charge to it, that, like, it's just not viable to spend 30 minutes, an hour dealing with a family that is continually infighting. So because obviously there's other patients to see, there's other things to do, but I think hopefully that helps a little bit. Definitely a hard situation.
Yeah, that is, I think the recognition that it's a difficult situation, but I think that approach of having, well, it feeds back into what you had mentioned earlier, that respect piece where, we separate the perhaps the patient as well as the trusted other, the child, the adult child, and then it gives a chance to interact with the patient and on that level, but also at the same time allow for some more functional discussions. Because you're right, we have seen plenty of situations where everything just breaks down. So I really love that approach in terms of just health distribution in general when you're having a visit, but let alone if you're wondering if there's abuse happening. So those are great points. I do see that there was a question over here about what to do with mental health and self-care in the Latinx community. Again, how would you approach a situation where you feel like there are some mental health needs and the patient may benefit?
Yeah, I'd say that the mental health conversation is very fragile, especially with older males. I know that I feel like a lot of this presentation is focusing on older Latinx males, and I think that's in large part because of the barriers that kind of fixate on them. But I think in general, I think Latinx women are much more open to that conversation about mental health. I mean, there's definitely like the taboo piece. There's families just don't want to talk. Don't want to talk about mental health needs, and
would one approach be for in that, like, for example, with the males and the females, again, is it that one-on-one sort of touch that might go a longer way? Because I do have kids who will say, we're having a lot of issues with self-neglect because my mom's depressed or my dad's depressed, and and we do feel like it would help them, that mental health piece. Would that be sort of the approach, to just sort of talk to them individually to try to build that trust, that it's more of a treatment?
Yeah, I'd say it can help. I think, well, I guess I'll share specifically in my family. I'll share about my family, which we've kind of treated it as sort of like, yes, you talk to them individually and you tell them like, this is an option for you. And you tell them like, you don't have to tell your family. But the family kind of knows and knows what's going on. So it kind of goes unsaid, which I realize might not be the healthiest way to approach it. But if it gets them in the door, I think that we consider a win. So I think even just having that swept under the rug, if you have just the slightest opening to doing it, I think taking advantage of that and offering that as sort of just like, it's just another doctor's visit. Mm-hmm. Just like, you're not going to therapy, you're going to the doctor, right? Mm-hmm. Because you need to go to the doctor, and just leave it at that. You don't need to talk about it. Mm-hmm. So that's my family. Other families obviously are different, so I don't want to give like that like an official professional recommendation, but that's kind of what's helped.
Well, I mean, it's interesting you bring that up, because you had brought up in your talk about also making use of family advocates. So there's this balance of, I think, the cultural aspect to make sure that we're respecting the elder, but at the same time utilizing the family advocates, as well, to sort of bolster that messaging. So so I could see how that would be helpful. So so you can sort of see emerging, and it's great that we're talking about this, that it all starts with us appreciating these dynamics, because there's that sort of a little bit of a narrower path, it sounds like, where we have to approach it sort of both ways, with making sure that we're honoring the culture and the respect of the elder, but at the same time, like, understanding the family unit is so strong and important that there are these advocates we need to make use of as well. Is that fair to say?
Absolutely, yeah. So it's taking that barrier of familia and kind of turning it on its head to make it work for you, right?
Yeah.
So giving them a sense of like contributing to the problem, because I'd say like it can be really easy for it to spiral out of control and have the family sort of like pile on to the older adult and like, kind of force them to do things. And getting them on board on sort of a more tactical, like nuanced approach to getting them to do to follow certain professional recommendations, I think is pretty helpful. So
Great. Dr. Galdamez, I also wanted to touch a little bit about the issue of the mistrust. All of us in the audience are providers, a lot of doctors, nurses, social workers. And when we hear about the mistrust piece, I think you offer that, it needs to be built up. But is there a particular, way that over those visits we can build up the trust? It sounds like, obviously language and making sure we address that and to do our best to overcome that barrier. But any other tips for how to, again, build up that trust?
Yeah, I'll say that. Yeah, the mistrust piece is huge. There's a range of how the Latinx community sees healthcare practitioners. So it can range from complete distrust to sort of even like a reverence, like this person has achieved a lot educationally, intellectually, so I better listen to them. So huge range, but I'd say, I mean, even myself, like if I'm going to the doctor, I'm wearing something that like shows that I have my PhD and I was like in higher education, just because like I've had experiences where physicians have dismissed my concerns and have dismissed the concerns of my family. So yeah, we can start there. Like, don't dismiss pain, don't dismiss concerns. Act like what they bring up to you is serious. Even if it doesn't, like, if it's not like super clinically serious, like just giving the general sense that you are taking it seriously means a lot. And I think just like basic conversation that isn't medical goes a long way. So like, you're an MD, the education barrier can be really intimidating. And sometimes patients want to build just like general rapport before we start delving into the heart stuff, just like maybe I have a heart problem. I don't want to start talking about my heart problem immediately. I want to like know how you're doing. So yeah, and I'll also say that like some patients want to learn and they really want to be educated, and the education barrier is also really intimidating. So like taking it slow with them. I've definitely had like aunts who like they wanted their whole lives to be nurses, but they never, they couldn't have like that. They didn't have like the socioeconomic status to go down that path. So every doctor's visit for them was really exciting. Like they really wanted to learn from the doctor and to kind of feel like they were valued in some way, even though they were never actually part of that professional community, right? So yeah, I think what also goes a long way is like a visible, tangible kindness. So like when you walk into the room, being happy to see them, having that feeling of like, like a family member. If like a family member walks into a a room with a Latinx family, like there's a sense of like, welcome, come in, it's great to see you. So kind of replicating that, mirroring that, I think will go a long way too.
I think as we have this conversation, I hope with the audience, I think what is emerging for me is this idea that, we need to respect, all of our, patients and their individuality, but, it's not a one size fits all. And to be able to get the most out of, our services and, to make sure that we can secure the patients, that we need to approach them with some of these concepts in our minds, that when we walk in the door, we have to understand in general, we may want to be sensitive to some of these, especially if it's apparent in our conversations that, there's issues like mistrust or communication barriers. Because, you're right. I think a lot of us, especially in training, we've seen models of physicians and nurses and other staff go in, without attention to this detail. And then we wonder why, okay, well, why are there these fallouts, happening? So this is great to have a lot of this information. I did have one question about, multiple generations, oftentimes, and I think there's some questions that sort of reflect this in the chat. A lot of children expect or are expected to be caretakers, it sounds like in some of these communities. And they're not necessarily, prepared necessarily. And it becomes a situation where oftentimes they may have to tiptoe around situations to not upset or anger the patient or to make them feel like their needs are not met. So how do you engage multiple generations under one roof where there's these dynamics, happening where we feel like we can get the patients to, sort of understand and to feel that, that they're not being sort of forced to do something?
Yeah, great question. I think for me as a young boy, having to translate and kind of do that caregiving thing for my grandparents, I think what was helpful for me for the super young generation that you might encounter is like taking them aside and kind of forming like a team, giving them a sense that like you're working on this together. Like this is something that that like, hey, this is something that you can help me with. Why don't we talk about like your grandmother? Is there like, are there certain things that like she gets kind of upset about, or like is there are there things that she responds well to? There's little kids specifically, like they observe a lot and they remember a lot. So like I think they can kind of be like a fountain of knowledge for you to like to really understand. But I think other generations, I'd say like it's definitely like a read the room sort of thing. It could be that like you have a separate conversation with all the people who've joined them for their office appointment, or just some of them. And I think being mindful of like, is there clearly any tension between, the people who are accompanying, and being mindful of like, of your role there, right? So, are you being seen as someone who is like an authority and should be respected? Are you being seen as a teacher? Are you being seen as a tyrant? Like, are they scared of you? These are all things that I think will go into making your decisions about how to like interact like one by one. So yeah, Great. Difficult question. I don't know if I can give like a super comprehensive answer, but that's sort of like my general views on it.
Yeah, well, I think a lot of the concepts we talked about today are good approaches to all feed in. Again, it's sort of a multifactorial how we would sort of approach, I think a Latinx elder and their household. So, Dr. Galdamez, this has just been such a wonderful time talking about these concepts. And, I think that, this has really done, wonders for our community. And just want to thank you so much for coming to speak to us today. And hopefully you'll join us again another time. But thank you so much.
Absolutely. It was my pleasure. Thank you.
Great.